My name is Luhan, just graduated from medical school. I was assigned to the ER as a resident. Tonight is my first night shift. They say no one wants to work the ER, but I believe saving lives is sacred no matter where you are. Doctor, my husband's stomach pain is unbearable. He had some barbecue tonight and drank 2 bottles of beer. He says it feels like a knife twisting in his stomach. Let's get a blood pressure first. Order an ECG, draw blood for labs. Troponin. Luhan, take this one. Acute gastritis is common. It's your first night on duty. Follow the protocol. Where does it hurt? It feels like it's tearing apart. Doctor, it feels like something's ripping inside. Have a seat over there. We'll get you some medication in a bit. Dad, his condition is exactly like my father's. Don't take the pain description too literally. Stomach cramps from alcohol can feel the same. He has an aortic dissection too. What's the blood pressure? Right arm, 89/102. Check the left arm again. 1 reading is enough. Let's do the ECG first, Nurse Chun. Check the left arm too. 143/88. A difference of over 40 between arms. That's a red flag. Dr. Zhao, I suspect aortic dissection. We need an aortic CTA immediately. Call cardiothoracic surgery for a consult. Doctor, isn't it just a stomachache? Luhan, don't scare the family. You can't just throw around a diagnosis like aortic dissection. You're a trainee resident. Finish the basic workup first. He has tearing back pain, significant BP differential between arms, cold sweats, hypertension. We can't just treat this as gastritis. There's no time. I said follow the protocol. It's 2 a.m. You want a CTA and cardiothoracic consult? If it turns out not to be a dissection, who's covering for you? It hurts. The pain is spreading to my back. Nurse Chun, take him to the resuscitation room. Start 4 line, get him on the monitor. Dr. Zhao, I'm requesting an emergency aortic CTA. You're requesting it on what authority? Because he might not survive the next 40 minutes. Why isn't he out yet? Why isn't he out yet? It really is an aortic dissection. Are you crazy? You call Director Gu directly? Dr. Zhao, if we don't call now, he won't make it off the table. Make the call. Who's this? Director Gu, this is Luhan. Yeah, resident. Type A aortic dissection. 49-year-old male. Onset less than 2 hours ago. CTA is done. Sending you the images now. Huh, open the door. So you're the resident, Luhan. Yes. Jingxi Hospital's getting bold. Residents calling in the chief of cardiothoracic surgery at 2 a.m. Director Gu, this is urgent. He's just worried about the patient. Nature of the pain. Upper abdominal pain with tearing. Back pain and cold sweats. Onset under 2 hours. Anesthesia to evaluate first. Blood bank. Prep blood. Prepare for bypass. Write clearly why you bypass the chain of command. The department will ask at morning rounds. Medical affairs might ask too. If something goes wrong, your name is first on that request, but he's still on the table. Exactly why you document the preliminary diagnosis now. If he doesn't survive, these notes are what they'll scrutinize. If you don't write it, no one else will make that call for you, Director Gu. The tear is in a dangerous spot. He's in surgery now. He got here in time. He has a chance, Luhan. Your phone, don't turn it off tonight. When surgery's over, I have a few questions for you. Saving lives is a great virtue. Successfully saved a dying patient. January 4th reward. Medical skill unlocked, 1/4. 3 more to go. What exactly is this system? If I save 4 patients, I wonder what the reward will be. Doctor, he drank too much. Fell down. Can you take a look? Doctor, he's drunk and fell. Please check him. In a lock zone and put him in observation. Misdiagnosis probability, 71. Effective treatment window, 38 minutes. Dr. Joe, he's not just drunk. Right pupil is dilated. Sluggish light reflex, abnormal twitching in the right hand. We need a head CT now. Are you sure? Anisocoria. That's not explained by intoxication. Take him a CT. I'll call radiology. Why a CT scan? He just drank too much and fell. How much does a CT cost? Around 400. 400? He just had a few drinks. Are you trying to hit your quota on us? No. Just give him an 4 drip if he's just drunk. You can yell at me after the CT. I'll take it, but if he's bleeding in his brain, the minutes you're delaying, he might never wake up. Can you live with that? Fall after drinking. Another drunk one, epidural hematoma. Midline shift is already developing, so he's bleeding in his brain. ER here. Fall after drinking. Right epidural hematoma. Midline shift, decreased consciousness with seizures. He's seizing O2. Sets are dropping. Turn him on his side. Prevent aspiration, 91. 88, still dropping. Neurosurgery, we need you now. 81, still dropping. Don't let him bite his tongue. Pupils are unequal now, right pupil dilated. Light reflex is gone. Who sent a drunk patient straight to CT? Patient has occipital trauma, vomiting, decreased consciousness. Right pupil dilation, absent light reflex. CT just done. Lucky break. Transfer him to the or notify them. Anesthesia to assess on arrival. We can't wait any longer. Can't unlock it. Damn it, I can't unlock it. Use your phone to call. Call his mother. Ma'am, your son is here. He fell. He is bleeding in his brain. He's in the OR. Don't panic. Does he have an emergency contact at his phone? Do you have his insurance card? Wait outside the OR. The doctor will need your signature when he comes out. Did you sleep at all last night? Not yet. You better not tell me you. Did you get any sleep last night? Not yet. You better not tell me you. 2 big saves in one night. All by instinct, by vitals, and observation. Handwriting's ugly, but the content's fine. Go wash your face. In 10 minutes. Give me the timeline for both cases. Write it now. What you still remember clearly. When a medical affairs office asks you, they won't ask how urgent it was when you saved someone. They'll only ask what time you found it, what time you reported it, who was present, who signed. Successfully resuscitated a dying patient. 2 minutes, 4 seconds. Reward, medical skill. Text, that's 2. 2 more to go. And then. First case, Wang Dihai. Type A aortic dissection detected by ER resident Luhan. A resident actually diagnosed an aortic dissection. Second, Zhang Xiaolei. Acute epidural hematoma detected by Luhan. Again, 2 cases. Same person detected both in one night. Flagged 2 high-risk patients. 1, he skipped the chain of command and called the chief of cardiothoracic surgery directly. The other, he pushed the patient into a head CT. Both were right, I'll say this plainly, but the protocol was wrong. Director Xiao, the situation really was urgent. When is the ER ever not urgent? If every resident goes straight to a department chief, based on their own judgment, then what's the point of the hospital's duty system? Who takes responsibility if something goes wrong? Who explains it when a family complains about excessive testing? Who signs if a patient dies during transport? Yes. You save people, that's a good thing. But right now you're not an attending, not a chief resident, and certainly not a department chief. You can offer opinions, but you can't take over a resuscitation. I didn't take over. I flagged the high-risk signs. I documented the basis for the workup. All consults and test requests were logged in writing. Before anything was done, Dr. Zhao was informed and agreed. Zhao, you hadn't mentioned it before then. Let me remind you of something too. From now on night shifts, all high-risk interventions must be reported to a senior first. If you can't find one, report to the duty officer. Don't think that because you got lucky twice, you'll be right every time. Understood. Go write a report on the situation. Focus on how the protocol should change. I'm not asking you to list your achievements. This isn't a TV drama. The people you save won't line up every day to vouch for you. Morning meeting. I read your application for the ER residency. It says you hope to be on the front line, saving more people. A good aspiration, but remember this. You're a resident. Your file is with the education department. If there's a real protocol violation, it won't just be a scolding within the ER, suspended rotation, or sent back to your original unit without completing training. I'm not trying to scare you. Water's free, but that's not how you use it. Scared now? Good, you should be. Fear is how you learn that rules aren't just for show. But if another one comes in tonight, would you still push for the CT? Chest tightness. Shortness of breath. Throat tightening. Probably reflux, esophagitis. Have you eaten anything irritating lately? Patient presentation. Female, 55 years old, high risk. Acute cardiac tamponade, misdiagnosis. Probability, 76. Next tryout. 3 classic signs of cardiac tamponade. Indicates the heart is mechanically compressed. It could stop at any moment. Effective treatment window, 31 minutes, 22 seconds. The system reward came in handy. Muffled heart sounds and a friction rub. Let's do an ECG first. You just came back from medical affairs. Can you stay calm? An ECG takes 2 minutes. It won't delay anything. Low voltage, electrical alternance. This doesn't look like esophagitis. It's not esophagitis. Muffled heart sounds, jugular venous distension, and dropping blood pressure. This is cardiac tamponade. I just have chest tightness. How is that a heart problem, doctor? Could the machine be wrong? This low voltage and electrical alternance means the heart is compressed by fluid and can't beat properly. The chest tightness. Your mother feels the throat tightening. These are the heart's distress signals. I'm not staying in the hospital. My husband is home alone. Just give me some stomach medicine. I'll go home and lie down. Start the chest pain protocol now. Draw troponin, but don't wait for the results. Contact cardiology. Don't give orders over my head based on one ECG. If you think it's not tamponade, I'll write your assessment into the chart. But if you're also suspicious, then don't argue about who spoke first. Tight. Can't breathe. Prep the defibrillator. Cardiac monitor is still okay. Cardiology on call. ER here. Acute cardiac tamponade. 55-year-old female. Muffled heart sounds. Jugular venous distension. Hypotension. EKG. Need urgent consult. Who is this in the ER? Resident Luhan. You're that resident from the other day. Yes, the ECG can be sent over right now. Hold on, I'll notify Chief. Is the family here? Yes. Has an ultrasound been done? Chief, please don't hang up. What do you mean? She won't make it if you walk over slowly. BP 8652 and dropping. JVD is getting worse. Prep the pericardiocentesis kit. Bring the ultrasound to the bedside. I'll be there in 10 minutes. Watch her blood pressure. Have the puncture kit ready. Bring the ultrasound over. Run fluid slowly for now. Who treated this as esophagitis? She presented with chest tightness and throat tightening. I thought it was reflux esophagitis. Chest tightness, shortness of breath, JVD. Put those 3 together and you still call it esophagitis? Low QRS voltage, electrical alternance. Were you going to wait until her heart stopped to call? Too much pericardial fluid. The heart is compressed and can't pump. Immediate pericardiocentesis and drainage. Get consent. Take your time writing the name. Just make sure it's complete. Needles in, aspirating. Dark red fluid is coming out. A resident shouldn't call a department chief directly. Fluid is drained. The compression on the heart is relieved. Oh, she's stable. Thank you, Chief. A resident. First time, he wakes up the cardiothoracic surgery chief. Second time, he wakes up the neurosurgery chief. And today, he drags me out of bed again. What exactly are you trying to do? He's trying to save people. Chief, don't take your fire out on my department. Then who am I supposed to take it out on? Your resident has woken up. 3 department chiefs in the last 2 days. The hospital's phone bill is about to go through the roof. But the patients were saved. Aortic dissection, intracranial hematoma, cardiac tamponade. All 3 patients were brought back. If you want to scold Luo Chom, I'll listen, but if you're scolding him for being reckless, you have to scold the ECG. the aortic CTA and the head CT scans first. Of course, rules still need to be set. From now on, Luhan is not allowed to take point alone on night shifts. He must report to his superiors and the department chief. Simultaneously, are you managing him or assigning him a bodyguard? Both, I'd say. Protective much? Luhan, next time you send an ECG, don't take the photo crooked. I nearly twisted my neck, try to read it. Observation, auscultation, inquiry. Just one more to go. Zoning out again. It's nothing, running that through your head again. They all say that as a resident. I shouldn't have called the department chief directly. They're right. But after he said that, the patient was stable. Or was it just luck? Rules are rigid.
But the patient lived.
Haha, Luhan, you're famous now. It's all over the hospital group chats. Guo Wang Shan He, Cheng Ming, Cheng Baijin. All three chiefs have an exclamation mark after their names. Someone even added a note. Chiefs who have been woken up by Luhan. Read into that what you will. Seriously though, do you have some kind of trick? Dissection, intracranial hematoma, cardiac tamponade. You caught all three. You got a third eye or something? Ask more questions, do a thorough physical exam. That's it.
That's it.
You don't even take your clothes off to sleep. You really are treating yourself like a workhorse for the ER. Schedule adjustment notice tonight. Luhan is with Zoe. Yuang at the resuscitation front desk for training. High-risk cases must be reported immediately. Is Luhan on tonight? Send me a copy of the schedule. Attention, all department chiefs. Please review the group rules. Do not harass the residents in my department. Who's harassing? I'm just asking. Jinyang asked if you're on tonight. What exactly do they think of you? A bed? Huh, they're afraid of my night shifts. Every shift I work, someone has to get out of bed. You're here. Eaten yet? No. Eat before you start your shift. Don't you dare collapse from low blood sugar. At the resuscitation desk tonight, the medical affairs office called again this afternoon. Asked if we were inducing tests. Got it. Keep it steady tonight. Not every patient is a dissection. Doctor, last night, I suddenly broke out in this rash all over. Itches terribly. Started any new medications recently? Day before yesterday, I had a sore throat. Took cephalosporin for 2 days. Drug rash from the cephalosporin. Stop the cephalosporin. Take an oral antihistamine. Apply a topical calamine lotion. If it doesn't clear up in 3 days, come back for follow-up. See? Not everyone needs resuscitation. Yeah, but you never know about the next one. Doctor, I fell while making a delivery this afternoon. The handlebar hit my chest. I'm a bit short of breath. Doctor, he fell while making a delivery this afternoon. The handlebar hit his chest. Just give me some painkillers. I still have a dozen packages waiting on the platform. How did you fall? Going downhill, the brakes gave out. I flew off the bike. The handlebar slammed right here. Felt fine this afternoon, but just now the breathing got worse and worse. System reward, medical skill activated. Current enhancement, palpation, tracheal deviation to the contralateral side. Signs positive for tension pneumothorax. Don't leave yet, sit down. Sit down? Why? Give me a painkiller and I'll get back to my deliveries. It's not muscle pain. Tension pneumothorax. The pressure in your chest cavity is building up. Your lung is being compressed. No way, I can still walk around. Prep a tube thoracostomy kit in the resuscitation room. Breath sounds completely absent in the left lung. Stat consult to thoracic surgery. Type in cross-match in the blood bank. Hyperresonance on percussion. Tracheal deviation, tension pneumothorax. Decompress immediately. No, I can't afford surgery. I still have packages to deliver. My mom is waiting for me to send money home. Let's save your life first. We'll worry about the money later. Green channel. Notify the duty officer. You contact the delivery platform. Contact his family. Contact the traffic police. Get him into the treatment room now. Hello. Hello. This is Zhang Lei from the ER at Jingxi Central Hospital. He was injured in a fall this afternoon. Tension pneumothorax. He needs an emergency tube thoracostomy. My son, he just said he fell. Didn't he, ma'am? He needs urgent treatment right now. Can you come to the hospital? If not, we need to inform you over the phone and record the call. I'll take the next high-speed train. Please, you have to save him. Done. His mom is out of town. Have some water. You've been on your feet for almost 2 hours. What are you thinking about? Thinking about my first night shift, writing that incident report. My hand was shaking so bad I could barely write. Everyone goes through that. I was the same back then. Got through to the patient's mom. She's out of town, taking the high-speed rail here. Tension pneumothorax. Very high intrathoracic pressure. Need de décompression plus tube thoracostomie. Lung re-expanded. His life is saved. Successfully resuscitated. A dying patient leveling up soon. Observation, auscultation, inquiry, palpation. All 4 complete. You're the resident who caught the pneumothorax. Found hyperresonance on percussion. Even palpated the tracheal shift. Good call. Starting tonight, Luhan's night shifts won't just have one attending. Add a second-line backup to the resuscitation front desk. Everyone keeps their phones on audible, no silent mode. You can save lives, fine, but one person can't carry every night alone. We're adding staff for you, not because you're not capable, because the ER nights are too long. From now on, your shifts have 2 people watching. Report anything first. Understood. That needle decompression tonight. You did it on your own. Next time, tell me first. He's changed. Current skills, observation, auscultation, inquiry, palpation, all unlocked. Mass casualty, event imminent, 15 people. Doctor, hurry. The whole table is vomiting. Everyone, initiate mass casualty protocol now. No photos in the resuscitation area. Put your phones away, triage by severity. If you can walk, go to the infusion area. If your blood pressure is dropping or you're confused, straight to the resuscitation room. Head nurse, call for backup. You take the infusion area. I'll hold the triage desk. Mass casualty event, 6 patients identified. Chief complaints, vomiting, diarrhea, abdominal pain. Suspected common source food poisoning. No vomiting, pupils dilated, dry mouth, flushed, skin, hallucinations. Anomaly flagged in mass scenario. This isn't food poisoning. Get a gurney to the resuscitation room. Why does he get to go to the resuscitation room? He's not even vomiting. This isn't your average poisoning. Director Zhao, this patient's pupils are dilated. Dry mouth, flushed skin, hallucinations. I suspect amatoxin poisoning. What did he eat? Didn't get a chance to ask. Go ask Nurse Chun, prep the gastric lavage kit. What did he eat today? He picked a basket of wild mushrooms in the mountains this afternoon. Came home and stir-fried a plate for himself. Went out with me to the night market this evening. Said his stomach fell off. Are there any mushrooms left? About half a plate left on the stove. Seal the leftover mushrooms as samples. Photograph them for evidence. Send to disease control and start gastric lavage. Administer activated charcoal, fluid replacement, and diuresis. Start liver protective medication. Have we checked coagulation? Drawn. Just send down. Have Salibanin on standby. Send toxicology screening at the same time. Anyone who ate at the same table should be registered and observed too. Toxic mushroom poisoning can have delayed onset. Add that to the protocol. 93. 91. Suctioning. Prepare for intubation just in case. Why does he get the resuscitation room first? We're vomiting worse than him. Vomiting more doesn't mean you're in more danger. The man in there can barely breathe. All 5 of you have vomiting and diarrhea, but you can talk, you can walk. No immediate life threat. Anyone who feels like they're about to pass out, raise your hand and I'll arrange it right now. What did Luhan say in there? No idea. But if Director Xiao personally sealed the mushroom samples, it's definitely serious. The smell on his breath is wrong. not the sour smell of vomit. It's a sweet, cloying, fetid odor. That's Feta hepaticus. Feta hepaticus, a precursor to liver failure. System notification, medical skill. Smell continuously active. Has the gastric lavage started? Tube just placed. Activated charcoal going in. Fluids and diuretics accelerating toxin excretion. Are the coagulation results back? Not yet. Save gastric fluid and blood samples for toxicology. Coordinate the mushroom samples with disease control too. Already sent Shuani to handle it. So it really is mushroom poisoning. I told him not to pick those wild mushrooms. PT is 18 seconds prothrombin time. 18 seconds. Liver function is deteriorating. Coagulation is abnormal too. Increase the liver support dose. Start N-acetylcysteine. Monitor coagulation every 2 hours. Have hepatobiliary surgery and the ICU on standby. If liver failure accelerates, transfer immediately. Oh, don't touch what was lavaged out. It's toxic. Let the nurses handle it. System notification. High-risk status confirmed. Patient is in an effective treatment pathway. There's still a whole room of people outside. You don't get a break. 6 people ate at the same table. 2 completely unrelated toxins. What the hell is going on? Is the one in front mushroom poisoning? Are we poisoned too? Activate the mass casualty protocol now. Move triage outside. Mild cases go to the infusion hall. Resuscitation room only takes red zone. You stand at the front. Watch for the ones who don't fit the pattern. Cough, cough, cough. Where does it hurt? Right upper quadrant pain. Been hurting for a day now. Vomited once just now. I thought it was something I ate too. Female, 58 years old. Acute cholecystitis flare-up. Murphy sign positive. Effective treatment window, approximately 4 hours. Keep NPO. Start antibiotics and consult surgery. Yellow zone, right upper quadrant pain. Suspected cholecystitis. Keep NPO first. Draw CBC. Contact surgery for consultation. He's just weak from diarrhea. Just give him some antidiarrheal meds. How long has he gone without eating? He's had diabetes for years. Diarrhea all day today. Haven't eaten anything. Didn't dare take his insulin either. Check a fingerstick glucose. 1.9. Effective treatment window. 15 minutes. Risk of brain damage. Resuscitation room. 40 milliliters of 50 dextrose, 4 push. Now it's not the diarrhea. Diarrhea all day, no food. His blood sugar bottomed out. If we hadn't caught it, his brain would be in trouble. Oh. All zones report. Red zone 3. Patient stable. Lu Yang's lactate is still climbing. Already contacted the ICU to prep a bed. Is he conscious? Was alert for a bit, now delirious again. His wife is outside and won't leave. Yellow zone, 12 patients, all on 4 fluids. The lady with cholecystitis ate something. Surgery will consult tomorrow morning. How long has she had the cholecystitis? She says it's been hurting for a day and a half. Kept thinking it was something she ate. A day and a half without coming in? She thought she could just tough it out. Green zone, 26 patients, 5 signed out against advice. The rest are improving. They can leave once their IVs are done. 2 non-outbreak related cases transferred to specialty. The hypoglycemic elderly man got dextrose. Consciousness recovered. Admitted to endocrinology for observation. The 2 non-outbreak cases, you flagged them. Who taught you to sort them that way? Outbreak-related versus non-outbreak related. Completely different presentations. So I separated them. When disease control comes to investigate, they won't have to redo the whole triage. What's the current status? Red 3, yellow 12, green 26, 2 non-outbreak cases transferred to specialty, no deaths. You came up with this triage method? The whole ER handled it. Luhan was in charge of triage and patient flow. He specifically focused on flagging the ones who didn't fit. Next, those who need observation get observed. Those who need rest go rest now. Submit a full incident report tomorrow morning. Send it to the Medical Affairs Office and Disease Control. I'll take the original triage sheet with me. When Zhanyang took your triage sheet just now, I saw the corner of his mouth twitch. What does that mean? Either he was impressed or he was thinking, this kid's going to be hard to manage. Finish your notes and go to sleep. More to do tomorrow. Reports are done. Anyone have anything to add? If yours isn't done, go finish it. If it's done, go back to the dorms and sleep. You're not on shift during the day today. Director Xiao, how long can I sleep? Until 6 p.m. Only 9 hours? Too little. Next. Mass casualty. You're on the triage desk. I'm going to sleep. Accommodation. Those two words are scarier to me than surgery. System stats. The ER in the mass food poisoning incident responded promptly. Triage was standard, no deaths. Commendation, hospital-wide. The whole team deserves the credit. Triage, resuscitation. IVs, registration. Not a single link broke. I know, but the reason that chain didn't break, the critical point was triage. The doctor said if we'd come half a day later, his liver wouldn't have survived. Thank you. Hey, how is he doing now? Xiaomai's fever is down. He can have kanji today. He asked me to make sure you got this letter. Starting today, you're officially on the resuscitation team. Yes, don't get too excited. The resuscitation team isn't just about accurate triage. There are hard battles ahead. Luhan Medical Skills Assessment System will auto-flag individuals inconsistent with the main record or inconsistent with group events. Zero mortality, you're weak. Complete 7 consecutive night shifts with 0 ER deaths. Current progress, 7/0. I used to worry you'd blow a hole in the ER workflow. Now I worry you'll just plug the holes yourself. One person can't plug them all, so I need a checklist. What checklist? A nighttime high-risk warning checklist. Turn the pitfalls we've hit these past days into items. Post it at the triage desk. The next person on shift sees it. They won't have to start from scratch. Write a draft and report to me. The draft? Not yet, but I've logged every step these past few days. Item 1, aortic dissection. Chest/back pain with asymmetric bilateral BP. I nearly missed it on my first day, almost let it slip. Write it down. Item 2, epidural hematoma. Unequal pupils, altered mental status. What's item 3? Cardiac tamponade. Chest tightness, shortness of breath, muffled heart sounds, jugular venous distension. Just these 3? There's also pneumothorax. Tympana percussion after chest wall trauma. Tracheal deviation. Not enough. You've encountered far more than this. This checklist can't become a blame stick. What do you mean? When frontline staff see the checklist, their first thought will be, will I be blamed if I miss this? Instead of is this patient at risk, the checklist is a reminder, not a shackle. Add a note. I have a condition too. Go on. Don't write it all fancy. If the writer understands it, but the user doesn't, it's as good as useless. You write one and show me. For patients who look fine, first ask why they look fine. A typical chest/abdominal pain, but with abnormal vital signs. Do not simply triage as ordinary stomach pain, anxiety, or post-alcohol discomfort. First night's done. 6 more to go. It's already posted. Jiang Yang reviewed it this afternoon. Doctor, my dad's been vomiting blood since this afternoon. Black blood several times. How long has he been vomiting? Started around 3 p.m. He said it was just an upset stomach. Told me not to call 1-2-0. Said he'd tough it out. Then just now he vomited a whole basin. That's when I called. Is his abdomen distended? Yes. It's so swollen, it's uncomfortable. Any history of cirrhosis? Yes. Diagnosed 3 years ago. He's been on medication since. Patient, Sun Daoyuan, male, 45. Cirrhosis with portal hypertension. Gastric variceal rupture with bleeding. Misdiagnosis probability 65. Hemorrhagic shock warning. Countdown 23 hours. Dr. Zhao. Cirrhosis history. Variceal rupture with bleeding. BP Njolsvankettu, Utven, HR 128, Massive Yi Bleed. Move to the red zone, open 2 large bore IVs. Rapid Crystalloid Resuscitation. Type in cross-match, stat, consults to GI and surgery. 0 negative, 400 milliliters arriving in 15 minutes. Crystalloids to hold him over. Transfuse once blood arrives. He's vomiting again. Start vasopressors. Start octreotide infusion. Open the Sangstaken, Blakemore tube, and have it ready. Who called? I did. Cirrhosis. Variceal rupture. 2 episodes of vomiting. BP below 80. Is the endoscopy suite ready? Just notified. Machine is booting up. Can't wait for that. Bring the bedside endoscope here. I'll do it in the resuscitation room. Bear with it. I'm going to plug the bleeding point. If you vomit, turn your head to the left. Found it banding now. Bleeding stopped. Blood's here. Transfuse now. Admit to GI for inpatient care. Monitor closely for rebleeding. We need to add the GI bleed item. You write it. For the lower GI bleed item, I suggest bolding it. List cirrhosis history separately. If a patient with cirrhosis comes in, check for varices first. For the elderly, head trauma item. Anticoagulants must be clearly documented. Aspirin, clopidogrel, warfarin. Ask about all novel oral anticoagulants. Don't just ask if they're on anticoagulants. Laypeople don't know what anticoagulants are. For the cardiac item, chest pain with diaphoresis. ECG can be done just once. If the first is normal, repeat in 30 minutes. The directors are starting to fight over territory. On your little checklist, 2-week trial. Each department submits additions to the ER. We'll review results in 2 weeks. So you're Luhan. I hear all the department heads are now afraid of your night shifts. Director, it's mainly that the heads don't sleep much. Can't blame him for that. Fear's a good thing. What a hospital fears most isn't sleeplessness. It's when no one's awake when they should be. The community clinic sent him over for a tetanus shot. He got a nail stuck in his hand. When did that happen? Once last week, he put a Band-Aid on it. Yesterday, he got stuck again in the same spot. Any discomfort lately? Can't open his mouth. Jaw is locked. Neck is stiff. Legs are cramping too. Dr. Zhao. What's wrong? Can't open his mouth? Trismus. Neck rigidity. He's not here for a tetanus shot. He already has tetanus. The wound is infected. How long since the dressing was changed? Band-Aid went on last week. Never took it off to check. Didn't change it for a whole week. He said if it didn't hurt. No need to bother on a construction site. Who doesn't just tough it out? Not good. He's starting to spasm. Turn off the lights. Don't shout. Tetanus patients can't have any stimulation. It'll worsen his condition. Tetanus progressing. Symptoms worsening. Trismus. Neck rigidity. Opisthotonos. Airway spasm risk. Countdown cannot be precisely estimated. Once laryngospasm occurs, the effective treatment window is under 3 minutes. For diazepam, have tetanus antitoxin skin test ready. Prepare for intubation. Has infectious disease been called? Yes. Minimize environmental stimulation. Close the curtains. Silence all phones. Don't turn on lights in front of him. How old is the wound? At least a week. Haven't dealt with one. TT skin test done? Done. Negative. Already administered. Does everyone have their troponin? Pharmacy is preparing it. Said it'll be here in 20 minutes. Administer as soon as it arrives. Dose calculated by weight. Maintain the airway first. Don't let his throat close up during a spasm. There's necrotic tissue in the wound. Needs debridement, but we can't move him right now. He seizes at the slightest touch. Is he going to die? It's life-threatening. So we can't treat this as an ordinary wound infection. Stable for now, but tetanus spasms will recur. Airway obstruction is possible at any time. He needs to be transferred to the ICU. Isolation in a dark room. Dedicated nursing care. Is there an ICU bed available? One just opened up. Move him over. I'll compile it into the official version tomorrow. Messy handwriting, but it works. As much as I want to complete the system and get the reward, I'd rather no patients come in at all. May the world be free of disease. That's every doctor's wish. Looks like tonight will be a quiet one. Don't you know the taboos in the ER? Some things you just don't say. Doctor, he's got chest pain. Is it a heart attack? How long has it been hurting? Half an hour. It started suddenly while he was drinking. How much did he drink? Half a bottle of Bailey's, plus a few beers. ECG is normal. Press here. Does it hurt here? Yes. It's not a heart attack. Alcohol-induced gastroesophageal reflux, plus possibly a bit of costochondritis. So, does he need a CT? No. I'll prescribe you some acid suppressants. No more drinking tonight. Come back if the pain gets severe or if he vomits blood. Your hands are shaking when you did the ECG. I'm used to it. Used to what? Used to being afraid. Used to the uncertainty. Luhan, have you been standing all night? Sit down and rest. You need to conserve your energy, even when there are no patients. Who's on duty tonight? He, Chongmin, and the front desk/triage team. Then I can turn my phone off. Turning your phone off has nothing to do with who's on duty. It'll ring just the same. Then I'll keep it on. What's the situation tonight? 1 gastroesophageal reflux, 2 soft tissue contusions, 1 cold with fever. No high-risk cases. No high-risk cases, and you're even more tense? I'm just not used to it. Here we go again. Luhan. There's a patient at the door who took cefazolin and drank alcohol. He's crashing. Cefazolin with alcohol. He's having an asthma attack. 2 puffs of albuterol didn't suppress it. He had a cold the day before yesterday. Started coughing badly yesterday. Dr. Zhao, severe asthma. Breath sounds nearly absent in both lungs. Oxygen via face mask. Add nebulization for methylprednisolone push. SpO2 is 87. Poor response to medication. Start BiPAP. If oxygenation drops further, intubate. I can hear wheezing now. That means part of the airway is opening up. Admit to respiratory medicine. If the infection isn't controlled, it'll flare up again. If it's stabilized, but then an attack lasts over 10 minutes and won't subside, come straight to the ER. Doctor, he suddenly vomited tonight. Said his stomach hurt. We thought it was heat stroke. Gave him Huaxiang Zhengqi water, but it didn't help. What's your name? Lin Xiaobai. Have you been drinking a lot of water lately? Frequent urination too? Have you lost weight? Lost over 10 pounds? Dr. Zhao. Fruity breath. Polyuria, polydipsia, rapid weight loss. I suspect DKA. Emergency consult with endocrinology. Move the patient to the resuscitation room. Kussmaul breathing, strong ketone odor. Start fluid resuscitation. Low-dose insulin infusion. Monitor potassium closely. Once acidosis corrects, potassium will drop. Doctor, how is he really? Who gave him the Huaxiang Zhengqi water? I thought he had heat stroke. Huaxiang Zhengqi water contains ethanol. Giving that to a DKA patient. You're pouring fuel on the fire. Shall we? Hello, I'm Lin from the ER at Xin Yuan Central Hospital. Xiaobai is diagnosed with diabetic ketoacidosis. Needs emergency treatment. He only vomited twice tonight. I'm Pei Wei from endocrinology. Type 2 diabetes presenting with first episode DKA. There's a risk of cerebral edema, but it's manageable. We need you to come to the hospital to sign the consent form. I'm on my way. Some things really shouldn't be said. Menstrual cramps. My period was late this month. I didn't think much of it. Half an hour ago, she suddenly said her stomach hurt at work. I thought it was cramps, gave her a cup of hot water. It just got worse and worse. It hurts here. It hurts more and more. When was your last period? Ah, it's been delayed by 6 weeks. I didn't think it could be that. Dr. Zhao, 6 weeks, amenorrhea. BP 96, heart rate in the 130s. Do an HCG first. If positive, ruptured ectopic pregnancy. Emergency consult with OBGYN. OBGYN, ED suspects ruptured ectopic pregnancy with bleeding. Requesting Director Yin come immediately. Ectopic pregnancy. She just has cramps. Cramps don't drop your blood pressure to 60, and they don't make your heart rate 130. There's blood in her abdominal cavity. We can't wait any longer. Notify the OR, open the green channel. I'll scrub indirectly. Prepare blood products in the cell salvage machine. Am I going to die? No, the OR is already prepped. Her husband is on a business trip out of town. Contact the family first. Surgical consent can be completed in the OR. Come with me to register. Stay awake. Once you're in the OR, you'll sleep through it and be fine. Move her to the OR fast. Wait here. I'll come out and tell you when there's news. Director Yin, can I observe the surgery? Do you know what you're looking at? I want to learn. Stand to the side and don't get in the way. Don't touch anything. BP Hetvenjods Utven. HR 145. SPO 291. Speed up the fluids. Start pressors. Significant hemoperitoneum. Suction. Clear it first, then we'll see. Found it. This is the site. Partial salpingectomy. Both sides are clean. Irrigate the abdominal cavity. Check for any other bleeding points. 0 mortality. ED weak progress. Phase 5, page 5. 0 mortality. Current skill, observation, auscultation, inquiry, and pulse diagnosis. Note, difficulty will increase significantly from page 7. Multiple countdowns may appear and run simultaneously. Got it. Ruptured ampulla of the fallopian tube. 1,200 cubic centimeters of pooled blood. 600 cubic centimeters autologous blood transfusion. Caught it early. 10 more minutes, and it wouldn't just be a tubal resection. Surgery's done. Bleeding's under control. Part of the left fallopian tube was removed, but she'll make it. How'd it go? Attending Yin performed it. Patient stable now. Out of space. Get a bigger sheet. Surgical skills. The system only used to give diagnostic hints. Now it's granting hands-on ability. Multi-car pile up 3 critical casualties. Only 1 resuscitation bay left. Activate the mass casualty protocol. Luhan, you do triage first. XIN, E-page. General surgery and orthopedics. Now, Fang Yao, open up resuscitation bay 2. Zhang, you on E, right occipital isolated fracture. Treatment window, 10 minutes, countdown started. 3 countdowns popped up at once. Director Xiao, the second patient should be the most critical. You start the diagnosis, I'll be right there. Where does it hurt? Chest hit the steering wheel. Can't breathe. Left-sided tension pneumothorax. Was thoracic surgery called? Yes. Director Ding said 15 minutes. We can't wait 15 minutes. O2 sat is 86. Need to do a chest drain. You confident? Yes. Do it. The third one isn't a pneumothorax. ECG shows ST elevation. Acute MI. Director Xiao has a fracture. This one needs ortho in the OR. Has ortho arrived? On their way. Needles in. It's up to 94 now. For the MI patient, He Changmin looked at the new map. He wants us to send him straight to the cath lab. Send Fang Yin, you go with the transport. Has ortho arrived? They're here, taking the other one. Where's the pneumothorax patient? Already managed. Who did it? Our resident, Lu Han. Spot on landmarking. Water seal connected properly. Get a CXR to confirm. That resident has steady hands. Where did you find him? He walked in on his own. The ED can't hold on to people like that. Keep them for now. Surgical skill, perfect grade. Suturing prerequisite, 2 satisfied. Complete observation, shift tonight. Unlock conditions met. Status reports from all teams. All 3 casualties treated, no deaths. Ortho admitted the fracture attending. He did the PCI for the MI himself. All traumatic wounds have been managed. Good. Starting next week, you're officially on the front line. Resuscitation rotation. Yes, sir. This week's night shifts. 0 deaths. You know what that means, Luhan? Luck is part of it, but luck doesn't stay on your side for 7 straight days. Ichamin called me. The MI patient, from entering the cath lab to balloon inflation, 23 minutes. You went from triage to diagnosis in under 5 minutes. Those 5 minutes were the minutes that save his life. My judgment won't be that fast every time. I know, but when you're in that position, someone lives because of your call. Director Zhao, what's different about the front-line resuscitation rotation? Before, you were at the triage desk, screening patients, handling things from the back. Front-line resuscitation means you stand at the very front. Whatever comes through the door, you take it first. Understood? Go home and rest today. Starting next week, you need to prepare for a different kind of fight. Starting next week, you're on the front line resuscitation rotation. Director Xiao mentioned it yesterday. He knows you did the chest drain. Ding Xiao called. Said your landmarking was spot on. It was an emergency. Couldn't wait for thoracic surgery, right? What you did today. A month ago, you wouldn't have dared. A month ago, I really wouldn't have. Everything's handled. The 2 in observation are stable, ready for handover. Go get some sleep, recharge. High-risk screening checklist, hospital-wide pilot. Starting today, you and Nurse Chun are in charge of auditing each department's implementation. Every department has to roll it out. Every single one, no exceptions. If any department resists, report them directly to me. Understood? We'll start the rounds today. This checklist was written with lives. It's not a box-ticking exercise. Understood. Van Nona, forever tattoos faded. Stuck it on first thing, right here. Everyone coming in and out sees it. Made a mini copy. Keep it on me at all times. That's a good method. I'll recommend it to other departments. The items are too vague. Confirm. Key steps. What counts as key? Vague things never get implemented. I added a page of specifics myself. Each item maps to a concrete action. Director Zhong, that's very thorough of you. Either don't do it at all, but if you do it, it has to be actionable. What high-risk screening checklist? Making such a big deal out of it. If we actually screened everything on that list, when would we get any work done? Honestly, it's just bureaucracy. Go through the motions and be done with it. Most departments have implemented it, but not everyone's on board. What do you mean? You try pulling a night shift and see. Doctor, he cut his hand. The bleeding won't stop. How did it happen? The knife slipped while chopping. Can you still move your fingers? Tendon severed. We'll manage the wound first. Repair surgery comes after. Dr. Zhao is handling a chest pain patient next door. He won't be free for a while. I'll take this one. Nurse Chun, needleholder 3 till 0 absorbable suture. Xiao Lu, are you sure this wound isn't shallow? I'm sure I've got this. 3, 4, 5. That's speed. What's going on? First time suturing a wound this deep. How is it? Shall we do the suturing? You did this? Yes. Even our residents don't have that kind of speed. Spacing, depth, approximation. Nothing to fault. I've lost count. Dr. Zhao, when you were tying the knots earlier, your hand was shaking a bit. Shaking is normal. Everyone's nervous the first time, but your hand speed doesn't look like a first-timer's. For the finger tendon repair, I'll contact hand surgery. They'll do it tomorrow. Tonight's suturing laid a solid foundation for the surgery ahead. Thank you, Dr. Zhao. From last week's drainage to now, you've done 2 things even attendings wouldn't be sure of. Well done. What are you spacing out for? Your hands didn't shake that bad, did they? When I was shaking just now? What if the needle had gone off course? Then would the wound you stitch be crooked? See, there you go. Shaking is normal, not shaking. That would be the real problem. First time suturing a wound that deep. Your hands shook, but the result was flawless. That's all that matters. Don't overthink it. Next patient's coming in. You got more to handle. You're already doing well. Side quest unlocked. Medication safety awareness during clinical practice. Identify cases where conditions worsen due to medication misuse. Current progress, 3/0. Doctor, my husband's had a fever for 3 days. Medicine won't bring it down. Now his stomach hurts too. How many days has the fever lasted? 3 days. It keeps coming and going. Last night it hit 39.5. What medication has he taken? You gave him all 3 of these at the same time? Yeah, the fever just won't break. I figured more meds meant more coverage. You can't just mix medications casually. Aren't they all just fever reducers? Bought them at the pharmacy. The label says 1 tablet per dose. 3 different fever reducers together? Do you know how much your liver can process in a day? The maximum daily dose of acetaminophen is 4 grams. Have you counted how much he's taken in 3 days? I just saw they were all for fever. Thought more was better than less. Fever reducers are still medicine. Acetaminophen and gammaling. They contain the same active ingredient. Stacking them together is like taking double the dose of one drug. The liver can't handle it. Alt is 800. Normal is under 40. Your husband has drug-induced liver injury. What? But he hasn't taken anything else. Just fever meds. Too much fever medication can kill, too. GI department. ED requesting doctor pay for consultation. Suspected drug-induced liver injury. Scara already showing jaundice. Classic drug-induced liver injury. Will he be okay? Treatment now is still in time. 2 more days, and it would be acute liver failure. Stop all medications containing acetaminophen. Note this down. Multiple acetaminophen-containing medications must not be taken together. Adult daily total should not exceed 2 grams. Side quest. Medication safety awareness. Progress March 1st. Medical Affairs Office is looking for you. 2 p.m. What about? No hither. It's a complaint. Do you know what's about? I have a guess. A month ago, Song Bae-yoon from the new ward. Her daughter, have a seat. Song Bae-yoon, 55 years old, admitted through your ED. A month ago, pericardial effusion. You remember? I remember. Her daughter filed a complaint. Excessive testing, excessive treatment. Her words, my mom just had chest tightness. Why drain the pericardial fluid? Were you just trying to charge more? I brought the records from that time. On admission, BP was 8550, HR, 130, distended neck veins, pulsus paradoxus. ECG showed low voltage QRS with electrical alternance. Ultrasound showed pericardial effusion, depth of 2 centimeters. I've reviewed all of this. Then let me state the diagnostic criteria again. Let's try it. Muffled heart sounds, distended neck veins, hypotension. Attention, all 3 were present. Without draining the fluid, the heart would be compressed and couldn't pump. Cardiogenic shock. Within 30 minutes. I know your judgment was correct. The problem isn't with you. When the daughter came to complain, she brought Song Bae-yoon's discharge summary. She brought the discharge summary, it says. Symptoms resolved after pericardiocentesis and drainage. Recovered. Discharged. She came to complain, holding the word recovered. You save her mother. Your records are clean, but the complaint goes into your file regardless of the outcome. Once it's accepted, it goes into your file. That's the process. You did the right thing, but not everyone who's been saved understands that. A complaint in your file doesn't mean you did wrong. It just means someone was unhappy. Working in the ED, you have to get used to it. I understand. What resentment, anger, frustration? His mother lived, right? And precisely because she lived, he's standing here complaining about you. If you hadn't drained it that day, he wouldn't even have the chance to complain. But I didn't think about all that when I did it. You don't need to think about it. You saw it, you did it. The patient lived, the rest isn't your concern. The ones you save won't always thank you, but you still have to save them. I understand. Doctor, he has a stomachache. Had hot pot. Drank some alcohol. His old problem flared up again. How long has the pain lasted? Started right after the meal, over 3 hours now. He just has a bad stomach. It hurts every time he drinks. Just give him an 4 drip and he'll be fine. Lie down, let me palpate. Ugh, rebound, tenderness positive. It's just a stomach issue. A stomach issue wouldn't hurt like this. CBC, amylase, lipase, triglycerides, liver function, blood glucose, calcium, abdominal CT, plain plus contrast. It's just stomach pain. Forget the CT. Why CT? So much radiation. It's not his stomach. Distended pain, rebound tenderness. All present. Onset after drinking and hot pot. I suspect acute pancreatitis. Pancreatitis? Can't be. Let me finish. Acute pancreatitis has a significant mortality rate. If it's severe, pancreatic fluid leaks into the abdominal cavity and corrodes surrounding organs. Far more serious than you think. The CT is necessary. Possible severe acute pancreatitis. Misdiagnosis rate, 58. Treatment window, 4 hours. Then how much will it cost? This isn't the time to discuss cost. He vomited, color is off, green with bile. Get him a CT on a stretcher fast. Severe acute pancreatitis. Peripancreatic fluid is obvious. There's already fluid in the abdominal cavity. Amylase is back, 1,200. Lipase is elevated too. General surgery consult for severe case. The peripancreatic exudate is extensive. Admit to general surgery, NPO, with GI decompression, level 1. Fluid resuscitation per attending. Monitor closely. Within 48 hours, if organ function declines. Transfer to ICU. Is he going to die? With treatment now, most cases can be controlled, but only if we don't delay any further. For more hours of delay, the outcome will be different. He just had a stomachache. We kept thinking it was a stomach problem. It's not a stomach problem. Still thinking about Song Bae-yoon's case? No, Lia. You've touched that paper 3 times since this afternoon. I'm thinking about something. Today's pancreatitis family. They also said it was a stomach problem at first. Song Bae-yoon's daughter also said it was chest tightness. Everyone thinks their own judgment is right, so I can't let a complaint stop me from running the tests I should run, or hesitate on what I should do. Then that settles it. Why are they calling you up there again? You're actually going? If I'm notified, I have to go. I asked around. It's Professor Fong from the Provincial Cardiothoracic Surgery. Rumor is he specifically targets process violations. Last time, at the provincial hospital, he made an attending cry. I'll answer whatever he asks. What did you bring? Records of every case I've handled these past few months. ECGs, CT reports, consultation requests, all photocopied. Does Director Xiao know? I'm not sure. Luhan. Yes. First year of your residency. First year. Within 3 months. You requested 4 contrast CTs above your level, 2 emergency consults, and directly contacted department chiefs 3 times. Is that true? Yes. The first, aortic CTA. What gave you the right to request it? What was your title then? I had no title. I'm a trainee resident. Before requesting, I noted asymmetric blood pressure in the patient's arms. A difference of 40 millimeters of mercury, tearing back pain, and the chest x-ray showed a widened mediastinum. These findings. Did your supervising attending see them? My attending was managing another patient at the time. I documented the vitals first, then verbally reported to Dr. Zhao Weiyang. Verbal report. Was there any written record? Yes. Before I requested the CTA, I left an electronic note in the system. The timestamp can be verified. Second case. Epidural hematoma. You requested a head CT. The patient had unequal pupils. Left at 3 millimeters, right at 5 millimeters. Consciousness went from alert to confused over an 8-minute interval. You're a trainee resident. You can determine intracranial bleeding just from pupil changes. I can't make the diagnosis. but I can recognize high-risk signs that require immediate imaging. Confirmation, and after your assessment, did your superior approve? Dr. Zhao approved. I signed it. Third case, cardiac tamponade. You called cardiologist He Chongmin directly, correct? I logged a written note after the call. Before Dr. He arrived, I did an ultrasound. You perform an ultrasound? The ED has a bedside ultrasound. I was trained on it by the time I arrived. The ultrasound image was already up. A fusion at 2 centimeters, pericardial tamponade. You saw it, documented it, reported it, but your authority doesn't extend that far. A trainee resident can flag a risk, but cannot lead the decision-making. Everything you did had the right outcome, but procedurally, I overstep. Good that you know. This list cannot become a precedent for every trainee resident. Ordering contrast scans at midnight, or calling chiefs above their level. One last question. The first case, aortic dissection. When you requested the CTA, what if it hadn't been a dissection? The family complains you owe verdict. The ED penalizes you. Medical affairs investigates you. What would you do? If the test comes back negative, it's overdisting. I'll accept the discipline. You're not afraid? I'm afraid, and you still did it. The patient's blood pressure was dropping. There was no time to wait. No time to wait. Those are the only words you've said. That don't sound like a trainee resident. I'll ask you again. If that CTA had been negative, then sitting here today, you should know what you'd be facing. Disciplinary action, delayed completion, sent back to my home institution. You knew the consequences, and you still did it? If I hadn't, that patient would most likely have died in the ED. If I did, the worst outcome is I get disciplined. If I didn't, the family signs a death certificate. Director Zhao, you've been quiet. I'm listening. Aren't you going to say something for your people? You said it better than I could. I have nothing to add. Keep your records. Director Zhang's checklist is good, but a paper on the wall can't govern everything. What matters is the person at the front, knowing when to wait and when there's no time to wait. Nervous? My palms are soaked. Doesn't show. I squeezed the file folder so hard it's damp. Did you understand what Professor Fong said at the end? Yes. The checklist is a tool, not a shield. And the other part? When to wait. When there's no time to wait. No checklist can teach you that, and a residency program can't either. Then what is? The number of times you stand at the front. Stand there enough, and you'll know. What you said today was harder than saving a life, but you said it. I had no choice. He asked him. Asking is one thing. How you answered is another. Some people cry when questioned. Some throw their superiors under the bus. You did neither. Good, get back to work. I've reviewed all your records. No issues. And there won't be any going forward. Luhan, that file folder needs replacing. You crushed it. Fell out of a construction site. Rebar went straight through. We used an angle grinder to cut off the outside part. It's still inside. How long? Over an hour. We tied a cloth strip around the leg to stop the bleeding. Good tourniquet. Whose cloth? Mine. Nothing else on site. Has general surgery been called? Yes, Director Ding said. 20 minutes. He's in another surgery. We can't wait 20 minutes. This wound is heavily contaminated. Every minute we wait, the infection risk doubles. I'll start the debridement. Surgical mode activated. Perfect grade debridement ready. Nurse Chun, hydrogen peroxide, normal saline, povidone iodine, debridement kit. Your turn. I'll do it. Lots of normal saline. How much do we flush until the runoff runs clear? That much. The contamination is too deep. If we don't clean it thoroughly, it's infection, necrosis, amputation. Dr. Liu, another car accident case, just came in. Dr. Zhao wants you over there as soon as you're done here. On it. Ready to close. Who did the debridement? He did. All the deep necrotic tissue is gone. Completely cleared, flushed with saline 4 times. Hydrogen peroxide and povidone iodine once each. What about cloth fragments? 6 pieces. The largest was right next to the deep fascia. Clean, cleaner than some residents I've supervised. I'll do the closure. You go handle the car accident case. Yes, sir. Luhan, when you rotate through cardiothoracic, next time stop by my service and check out general surgery. That technique is worth learning for you, too. Which department should I register for? Loading. 3 days ago, I was checked at another hospital. They said AIDS. They wanted me admitted. I didn't stay. Got some meds and came back. Name, Sun Chong. Emergency internal medicine. Exam room, 3 down the hall. Unresolved risk patient, Sun Chong. Male, 54. Outside hospital diagnosis. Cirrhosis with ascites. Admission recommended. Not followed. Current status. Registered, but not seen. Risk alert. Cirrhosis with ascites patient at risk of massive GI bleed at any time. How many people are waiting in exam room 3? 5. Sun Chong is 6th. Can't wait. I'm seeing him now. Mr. Sun, I'm Lu Han from the ED. Did you bring the test results from 3 days ago? Yes. The doctor said I should be admitted. I didn't think it was that serious. Went home, took the meds for 2 days. Felt much better. The ultrasound shows massive ascites, abnormal liver function. Platelets are only 58. You need to be admitted. No question. How much does admission cost? I'm a migrant worker, alone. How can I afford it? Go get an abdominal CT first. I'll put the order in for you. Where is he? Took a call and walked out. Which direction? Toward the main entrance. Still not answering. He's gone. Hello, Mr. Sun. This is Dr. Lu Han for the ED earlier. Your ascites needs immediate treatment. You can't delay this. Please listen. Cirrhotic ascites isn't something you can just rest away. Your platelets are only 58. You could have a massive GI bleed at any moment. A bleed isn't something you sleep off. It can kill you. I'm Fine. Doctor, don't worry about me. You got his info and contact details, right? Yes. Then you did everything you could. The patient chose to leave. You can't force him to stay. Cirrhosis with GI bleed. Male, 54. Name, Sun Chong. No family here. Brought in by a co-worker. I know him. He came in yesterday. I told him to be admitted. He left. Mr. Sun. Resuscitation room 2 for lines. Type and cross start. Octreotide drip, page GI, and general surgery. Blood isn't here yet. Blood bank says cross match takes 10 minutes. Crystalloid to keep him stable. Is the octreotide running? Just started. Hemoglobin is back. 58. Is GI here yet? Variceal rupture. Endoscopic hemostasis is ready. History of cirrhosis, ascites, platelets, 58. Classic variceal rupture. I'm going in. Found it. BAM ligation. Bleeding stopped. Admit to GI. Hold a bed in the ICU. Platelets are too low. It can re-bleed at any time. You called him yesterday to admit him? Yes. He said he was fine. Documented? Yes. Phone record too. Then you're covered. A patient has the right to refuse admission. You did everything you could, but he still bled today. If you hadn't made that call, he might have bled even earlier. You called. He didn't listen. That was his choice, not your fault. Don't beat yourself up. Next Monday, you're rotating with Director Ding's surgical team. Be prepared. Director Ding's surgical team? Director Zhao arranged it. You'll start with retraction. Understood. You're on Director Ding's team next week. Yeah, starting with retraction. Retraction is a skill job. Do it well, the lead surgeon is happy. Do it poorly, and he'll tear into you. You got experience? I retracted once and happened. It was decked to me. Ding Xiaoyang said my angle was wrong. Chew me out for 3 minutes in front of the hole, or so. What do you think matters most in retraction? Don't move. Retract where the lead surgeon says. And hold. Don't move unless told. No matter how much your arm aches. You endure. That's simple. That's simple? But not many can actually do it. Unlock condition. Serve as first assistant on at least one surgery. Nervous? I'm okay. Huh, last time you said okay. It was your first chest tube. Your hand shook. That was half a second. It doesn't count. Your hand can't shake during retraction. If Ding Xiaoyang sees you shake, he'll swap you out on the spot. You've said that when passing instruments. Watch his hands. If he wants forceps, his hand opens. If he wants scissors, his fingers make a cutting motion. You pass it before he even reaches. How do you know all this? I got yelled into it. Luhan. Director Ding says we're starting. It's a laparoscopic cholecystectomy, no peritoneum. Draw a card. Retractor. Expose Callow's triangle. Good hold. Forceps. Bovie, suction. How did you know I needed suction? Oozing. You need it cleared to keep dissecting. Cautery. You passed the suction before I even reached. How did you know it was suction and not gauze? It's a laparoscopic case. Can't use gauze. You knew what I needed without looking. Who taught you? Guess. Keep guessing. You're on tomorrow's surgery, too. Perforated ulcer repair, more retraction. Yes, sir. If your arm aches, endure it. I don't want to see you let go. Not like some people. How long has the pain been going on? Since this morning. It started around the belly button. Now it's moved to the right side. Any fever? Started this afternoon. Measured it myself. 38.2. Draw blood for CBC and C-reactive protein, abdominal CT, to confirm. Notify the or deprep table. You came alone? Can you reach any family? My wife is on a business trip out of town. I called and told her. She said she's rushing back. About the surgical consent. Let's wait for your CT results. Draw blood first. Who's the lead surgeon for the table? Director Ding is on duty today. Ask if he's available. Director Ding is in, or two, doing a bowel obstruction, at least another hour and a half. The appendix is suppurating. Waiting another 90 minutes doubles the perforation risk. Can't wait, can't wait. You want to lead the surgery? I can do it. How many have you done? Observe 3. First assisted once. Does Ding Xiaoyong know? Call him and ask if he agrees to remote guidance. I'll step up. General anesthesia complete, vital stable. Surgical mode activated, perfect grade. Appendectomy ready, confirmed. Suppurative appendicitis. Dividing the appendicular mesentery. Small vessel at the mesentery root. Got it. Clamping the appendicular base. Irrigating the abdominal cavity. No bleeding. Closing the abdomen. It's out. It's out. Blood loss under 5 milliliters. How's the purse string suture? Spacing is 2 millimeters. Knots are secure. How do you know the spacing is 2 millimeters? I counted while suturing. Did you save the recording? Saved. I'll review it after I finish this case. You've done an appendectomy before? No. From now on, Tuesdays and Thursdays. You're on my surgical table, fixed. Yes, sir. From retractor to lead surgeon. Takes others 6 months. You did it in a week. Don't guess next time. You know what to do. Mom, last week when I organized your pill box, I saw you'd added an extra warfarin tablet. I've told you 800 times, you can't just take extra of this drug. Did I forget to take it? If you forget one day, take it the next. What's wrong with taking one extra to make up for it? You took extra for 3 days. Auntie, besides warfarin, have you taken any other medication recently? No, nothing. He took this, ibuprofen. Bought it himself at the pharmacy for a toothache. Been taking it for 3 or 4 days. Toothache keeping you up at night? Auntie, you're on warfarin and taking ibuprofen. Ibuprofen is for pain. Warfarin is for the heart. They're unrelated. They are related, and very much so. Warfarin is an anticoagulant. It prevents blood from clotting. Ibuprofen enhances its anticoagulant effect. Taking them together, your coagulation function collapses. Your INR is already at 3.2. Normal is under 1.5. Any higher, and it's a cerebral hemorrhage. Did you hear that? Cerebral hemorrhage. I was away for 3 days on a business trip and didn't watch you. And you go and give yourself a brain bleed. I didn't know I couldn't take ibuprofen. Nobody at the pharmacy told me either. A pharmacy isn't a hospital. At least read the label before you buy something. The contraindications section of the insert. It's written there in black and white. Starting today, Stop all medications. Wait until your coagulation levels come down. Doctor, does he need to be admitted? 3.2. She needs to stay for observation. Can't discharge until INR drops below 2. Mom, did you hear that? Hospital stay, how many days? Depends on how fast the levels drop. If it's quick, 2 to 3 days. But my tooth still hurts. Have a dental department see you for that. No more ibuprofen, and no switching to another painkiller either. You must ask a doctor first. I'm posting this to the family group chat so everyone can see. If you're on anticoagulants, don't buy your own painkillers. If you're on anticoagulants, don't buy your own painkillers. Need to print extra copies of this. Post them in cardiology and geriatrics. Annie Zhao's INR came down to 1.8. She could be discharged tomorrow. Go over it again with her daughter before discharge. No drugs containing NSAIDs. Already told her daughter 3 times. Her daughter said she's going to lock up their medicine cabinet at home. Heart rate 48, BP 96/60ths. Family says he took heart medication. Not sure which one exactly. Put him on the monitor and check serum. Potassium, digoxin level, ECG. Classic fishhook pattern. Typical digoxin toxicity, ECG. Potassium 2.8, digoxin level 3.2. Toxic hypokalemia plus high concentration. He didn't take the wrong med. He took too much. Doctor, what's wrong with him? He was fine this afternoon after dinner. He said he felt dizzy. I thought he'd feel better after lying down. And these 3 meds are what he's taking. Digoxin is for the heart, I know that. Aspirin, I know that too. But this furosemide, I had no idea. Furosemide is a diuretic. It removes water. He told me his legs were swollen. Took 2 tablets to reduce the swelling. I thought it was like a supplement or something. It's not a supplement. It's a prescription drug. Water-removing drugs flush out potassium. Low potassium doubles digoxin toxicity. How many digoxin tablets did he take? Do you know how many he usually takes? The doctor said 1 a day. But a couple days ago, he said his chest was really tight, so he added 1 himself, then took furosemide for 3 or 4 days. Potassium got completely depleted. Digoxin toxicity fully released. His heart rate is 48 now. Normal is 60 to 100. Any lower and his heart will stop. Why didn't he tell me? Digoxin toxicity, managing now. Stop all medications. Replace potassium, monitor heart rate. Cardiology consult. Side quest. Quest complete. Reward. Medical knowledge base expansion. Common medication contraindications. Li Wenqing's family. Condition is stable for now. We'll do our best. Never adjust heart meds or diuretics on your own. Always ask a doctor. This one needs to be bolded, especially for elderly patients. Where's the patient in bed for? Finished his 4 hours on day shift, changed into his own clothes, and left at 4 p.m. No discharge paperwork, no CT done. Shen, what's the phone number for bed for? Hello, Mr. Zhang. This is Lu Han from ED at Qingshui Traditional Chinese Medicine Hospital. You left the observation unit this afternoon. Your CT hasn't been rechecked yet. You need to come back today for it. I feel much better now. My headache's gone too. Let's just talk about it tomorrow. The follow-up for a head injury can't wait. Some intracranial bleeding doesn't show up immediately. It can start a day or 2 later. You feel fine right now, but that doesn't mean there's nothing wrong in there. A CT scan means waiting in line and paying for it. I'll mark you as urgent, no waiting. We'll sort out the costs later. Come now. He'll come. Not sure, but last time with Suncheon. I didn't follow up the next day, and the ambulance brought him back. Doctor, I'm here. Had a meal and a shower before coming. I'll take you to the CT room. We could do the scan right now. Dr. Zhao, take a look. The epidural hematoma has enlarged. No pain doesn't mean it's not growing. By the time it hurts, it'll be too late. The hematoma is about 30 milliliters. It's still expanding. Surgery is required. Surgery? I was perfectly fine this afternoon. Mr. Zhang, you're bleeding in your brain. If we don't deal with it tonight, you might not wake up tomorrow. My wife has bad legs and can't come. My son is in Guangzhou. Give me your son's number. We'll get phone-recorded surgical consent plus your signature. Dad, what's going on? Hello, this is the ED at Shui Central Hospital. Your father's head injury. Follow-up shows an enlarged epidural hematoma. He needs emergency surgery. What? He said he was fine this afternoon. I'll get a flight tonight. Earliest I could be there is tomorrow morning. The surgery can't wait until tomorrow. We need your phone authorization now. I consent. Please take care of him. Director Zhong, we have the authorization. Or is ready. Bring him in, doctor. Good thing you made me come back. Hit a guardrail on my e-bike. The handlebar jammed into my abdomen. BP njolsvannet utven. HFSAS husodik. Peritonal to. Splenic rupture. Notify the or open the green channel. Type and cross 4 units. Where's the family? He lives alone. No family on scene. A co-worker is on the way. We can't wait for the family. Open. Is Director Ding in? Upstairs, 2 minutes. Director Ding, grade 3 splenic rupture. Non-clotting blood on tap. Needs emergency surgery. I'm coming down to prep. Splenic artery is intact. We can save the spleen. You sure? Small tear. Can you suture it? You do it. Is it stopped? Stopped. Clean instruments. What makes you so sure we can preserve it? The splenic artery isn't severed. The parenchyma is lacerated. It's not shattered. It can be sutured. Most grade 3s get removed outright. Spleen preservation fails more often than it succeeds. This one can be sutured. Next month, you're on my team. Formal transfer, upstairs. I'm already scrubbing in with you. Not as a helper. My name is on the schedule. Permanently on my team, my person. Yes. First appendectomy, you sutured like an attending. First splenic repair, you saved it. Next case, you do what I tell you. Whatever you need, I hand it to you. Don't wait for me to ask. Who's in charge here? I want to see your supervisor. And you are? Zhang Dufuisson. I just flew back from Guangzhou. My dad is admitted to neurosurgery. What did you do to him? Mr. Zhang had the hematoma evacuation surgery. He's recovering in the neurosurgery ward now. Recovering? This morning. He told me his head hurt. He can't eat. No energy at all before the surgery. He was perfectly fine. He just bumped his head. Mr. Zhang's son, you're the one who called that day? Yes, that was me. You called and made my dad come back for a CT. He comes back and gets cut open. I said I consented to the surgery, but nobody told me. He'd end up like this afterward. Mr. Zhang's current symptoms are normal, part of the postoperative recovery. After the hematoma is removed, the brain tissue needs time to settle back. Easy for you to say. How much has the hospital stay cost? Surgery, CT, medication. He's a retired worker. Pension is about $2,000 a month. Is that enough for you to put him through all this? What's going on? Zhang Difu's son, issue with postoperative costs. Let's talk in my office. Before the surgery, my dad could eat and walk. After your surgery, he's bettered and can't get up. You call that treatment? Zhang Difu's epidural hematoma was 30 milliliters and it was still expanding. Without surgery, he'd have brain herniation within 2 days. But you didn't say he'd end up in this state. Headache and fatigue for 3 days. Post-op is a normal recovery process. It's not a complication. His hematoma has been evacuated. The pressure on his brain is relieved. In about a week, his symptoms will improve significantly. That's what you all say now. Who's responsible if something goes wrong? The surgical record is here. Intraoperative blood loss. Post-op CT scans, all documented. You can take them to any hospital for a second opinion. My dad told me. It was a young doctor in the ED who called and made him come back. He'd already gone home. If he hadn't come back, the hematoma would have kept growing. What if it didn't grow? Maybe he'd have rested at home for 2 days and been fine. The CT doesn't lie. A 30-millimeter hematoma doesn't just absorb on its own. This isn't over. I'm filing a complaint. All the records are here. Don't worry about it. I'm not worried. but a complaint goes into your file for the second time. Heard about it. His dad's still alive. If he's well enough to complain, the patient's fine. He said maybe he'd have rested at home and been fine. You know, he wouldn't have been. The CT was in your hands. The people you saved don't come out every day to vouch for you, but the medical records do. If he's well enough to complain, the patient's fine. He said maybe he'd have rested at home and been fine. You know, he wouldn't have been. The CT was in your hands. The people you saved don't come out every day to vouch for you, but the medical records do. Quiet night tonight. Don't say that. Why? The moment you say it's quiet, something happens. The rule of the ED. Multi-vehicle pile-up on the expressway. 8 cars, initial casualties. 7 arriving in 15 minutes. Mass casualty, highest level protocol. Attention all staff, mass casualty. Highest level protocol activate. Notify ophthalmology, orthopedics, general surgery, cardiothoracic, and neurosurgery, all on duty. Clear to resuscitation bays. Nurse Chun, prepare blood. Notify the blood bank for emergency release. Zhao Weihang, you and Luhan handle triage at the front desk. Yes, Luhan, you stand at the front. Whoever comes in first, you take them first. Understood? Male, 40, steering wheel hit to chest. Chest pain, shortness of breath. Female, 35, ejected from vehicle. Right lower leg deformity. Male, 50, head hit windshield. Altered mental status. And one more. Pregnant, 28 weeks. Abdominal pain. Current trauma, activation. High acuity, level 4. Dr. Zhao, the third one. Head trauma, altered mental status. CT first. Page. Neurosurgery, ASAP. Second one. Right leg looks like a fracture. Control bleeding, splint. Wait for ortho, Nurse Chun. The fourth one, pregnant. Isolate her, in observation. Monitor fetal heart rate. Call OB. What about the first one? Let me check. Steering wheel hit to chest. Where does it hurt? Chest, 0/2. Sat 88, BP 95/60ths. Not a pneumothorax. Dullness on percussion. Could be pericardial or pleural effusion. Bedside ultrasound. My friend. Tube, thoracostomy. Prep the thoracotomy tray. Traumatic hemothorax, misdiagnosis. Probability 6. Treatment window, 25 minutes. Countdown, 25. Alarm. What's the status on the first one? Traumatic hemothorax, needs drainage. More casualties are on the way. Second wave of patients. Can you handle it? I can handle it. Then do it. Countdown, 25. Alarm. What's the status on the first one? Traumatic hemothorax, needs drainage. More casualties are on the way. Second wave of patients. Can you handle it? I can handle it. Then do it. BPDs ut holding steady. What about the second patient? Fang Yao is handling it in ortho. Pregnant patient, fetal heart rate normal. Fangkuo ish en route. Second wave has arrived. Male, 34, broken glass, penetrated left chest. It was pulled out at the scene. Now fragments have broken off inside. BP hetvenut utven. Heart. Glass pierced the pericardium. Blood in the pericardium. Next triage. Hypotension, JBD. Muffled heart sounds. Blood in the pericardium. The heart can't pump. 8 minutes. No time for the OR. No time for CT surgery. Dr. Gu is consulting at the Provincial People's Hospital. It'll take him 15 minutes to get back. Get him on the phone. Penetrating cardiac injury. Cardiac tamponade. Bex triad. BP hetvenut utvenyorts. Minute window. You won't make it back in time. I won't make it back. Do pericardiocentesis for decompression first. I'll have the perfusion team on standby. 5 minutes out. Needle decompression is only temporary. If there are clots in the pericardium, you won't be able to aspirate them. Do the tap first. Drain whatever you can. Don't let him die before I get there. Dr. Zhao, thoracotomy tray. What are you going to do? Needle decompression. If that fails, open chest right here. Prep the defibrillator, type and cross 4 units. Contact Dr. Gu's perfusion team. Dark red blood, aspirated. 20 milliliters, 30 milliliters, 40 milliliters. BP is coming back, stable for now, but the bleeding hasn't stopped. I know, the tear is on the heart itself. Needle decompression is only a bridge. It has to be sutured. Dr. Gu, aspirate 50 milliliters via pericardiocentesis. BP temporarily improved, but bleeding hasn't stopped. Can't wait for bypass. Have you ever sutured a heart? Done it in animal labs. Open the chest and decompress first. I'll be there in 5 minutes. Once you open the pericardium, find a tear. If you can suture it, I'll wait. Aspirated 50 milliliters via pericardiocentesis. BP temporarily improved, but bleeding hasn't stopped. Can't wait for bypass. Have you ever sutured a heart? Done it in animal labs. Open the chest and decompress first. I'll be there in 5 minutes. Once you open the pericardium, find a tear. If you can suture it, I'll wait for you. What's your progress? Pericardium is open, right? Ventricular tear, still bleeding. Surgical mode activated. Perfect grade cardiac, suturing ready. What are you going to do? Suture it. You can suture a heart? Yes. BP is drooping. Suture. That's good. One more stitch to reinforce. BP is back. 95/60ths. Drain the pericardium. Close the chest. Where did you learn that? From a textbook? Bookworm, your hands are steady. It was animal lab work. Yes, I used to practice on animals a lot. Animal labs aren't the same as suturing a human. I know, you knew, and you still sutured. You told me to. This patient's post-op care, CT surgery will take over. Write up the operative note tomorrow and give it to me. Yes, sir. Make sure the note is clear. I was present throughout, supervising. I was the primary surgeon. You were the first assistant, performing the main procedure. Yes, sir. Nice suturing. Go get some air. It's fine. Your hands didn't shake, but your face is white. Make sure the note is clear. I was present throughout, supervising. I was the primary surgeon. You were the first assistant performing the main procedure. Yes, sir. Nice suturing. Go get some air. It's fine. Your hands didn't shake, but your face is white. Oh, drink some water. All the other casualties are taken care of. The 2 with fractures are casted, admitted to the ortho ward. The pregnant patient had a placental abruption. Dr. Yin finished the surgery. Mother and baby are safe. The head trauma patient is in neurosurgery. Dr. Zhong is monitoring the hemothorax. Patient drainage is holding. What about the cardiac one? Post-op, sent to CT ICU. Dr. Gu's team is managing. You know how many came in tonight? 11. All of them survived. Good work. Mass casualty incident resolved. Lives saved, 11. Incident response rating, excellent. Surgical skill usage statistique. Suturing, closed thoracic drainage, cardiac suturing. Luhan, are you okay? I'm Fine. I heard you opened a chest in the resuscitation room. Yeah, are you crazy? Dr. Gu asked me to suture it. Gu Wangshan asked you to suture a heart? He didn't have another choice. Tonight, you saved 11 people. It wasn't just me. Ortho, neuro, general, and cardiac surgery all showed up. But you did the triage. The first hemothorax, you diagnosed it in 5 minutes. The cardiac one, you did the needle decompression in 8 minutes. Luck, you said that before, too. Director Zhao said luck won't always be on your side. Director Zhao. Sit for a bit. You did 3 surgeries tonight. Tired? No, liar. Go get some sleep. I moved your shift tomorrow to the afternoon. Morning off. No need. That's not a request. Sister Chun, tonight, without you all, don't think about that. You made the right calls. That's the result. Sister Chun tonight. Without you all, don't think about that. You made the right calls. That's the result. Ma'am, how long has he had the fever? 2 days. Started yesterday. Took fever reducers, but it didn't go down. What did you give him? Acetaminophen. 2 tablets. No effect. I figured if the medicine didn't work, I try a home remedy, physical cooling. Man, what's this smell? Biobil. I wiped his body with it. That's what we do back home. The fever breaks after wiping with it. How long ago did you wipe him with Bigio? Once this morning and again in the afternoon. The fever did drop a bit after wiping, but came back in the afternoon even higher. Does he have liver disease? Yes. Hepatitis B for years. Cirrhosis was diagnosed 3 years ago. Cirrhosis, and you wiped him with Bigio? Ma'am, did you know alcohol is absorbed through the skin? Even wiping the body absorbs it. I thought it would just cool him down. Alcohol absorbs through the skin, enters the bloodstream. He has cirrhosis. His liver can't metabolize it. The alcohol builds up in his system. It won't break the fever. It adds stress to the liver. Blood work is back. Alt is 320, double what it was on admission. Blood alcohol is 0.2, elevated. How much acetaminophen did he take? 2 tablets yesterday, 2 this morning. For total. An overdose. The problem is the liver enzyme levels doubled. It's the alcohol plus the liver disease. I just wanted to bring the fever down. I didn't know wiping with alcohol could cause this. For physical cooling, use warm water. 32 to 34 degrees Celsius. Wipe the neck, armpits, and groin. No alcohol. No viji. I won't do it again, I won't. For now, we bring the fever down first. Liver support therapy. Internal medicine consult. Observation overnight. Repeat liver function test tomorrow. For fever, physical cooling with warm water, not alcohol. Add this to the notice board in the observation unit. Don't just put it in observation. Put a copy on the public education board in the outpatient lobby. 2. Last month, cardiology had a patient who took ibuprofen and ended up with a GI bleed. Also self-medicating without knowing. Okay, I'll talk to the head nurse at outpatient. Doctor, is he okay? Caught it early. Fluids tonight. We'll check his labs tomorrow. What about his cirrhosis? The cirrhosis is a pre-existing condition. It's not related to this episode, but no more alcohol for fever. From now on, if there's a problem, come to the hospital. Side quest, home remedy awareness. Content, contraindications of alcohol wiping for fever. Key point, alcohol absorbs through the skin. Contraindicated in liver disease. Children and the elderly. This is the 3rd case this month. Stacking fever meds, warfarin with ibuprofen. Now alcohol body wipes. People have more home remedies than I thought. That's why we post these. If one more person sees it, that's one fewer incident. This is the 3rd case this month. Stacking fever meds, warfarin with ibuprofen. Now alcohol body wipes. People have more home remedies than I thought. That's why we post these. If one more person sees it, that's one fewer incident. Level 7. Perfect grade aortic dissection repair. What are you looking at? Nothing. Zoning out again. You've been doing that a lot lately. Thinking about what? Scheduling. What's there to think about with scheduling? When do you think I can rotate to cardiac surgery? Cardiac? Why the sudden interest? I want to try every department I haven't been to. How many have you done already? General, thoracic, neuro. Yeah, just one left. Cardiothoracic surgery isn't somewhere you just walk into. Guo Wangshan is extremely picky about who he takes. I know. Get some sleep. Early shift tomorrow. Starting next week, you'll rotate to cardiothoracic surgery for 1 week. Dr. Gu agreed. He called me yesterday. Said he wants you. Why? Ask him. I don't care why he asked for you. So I let you go. You know why. First page, Wang Di. High type A. Aortic dissection. You called Guo Wangshan to come fix it. You remember, right? I remember Guo Wangshan came that night. On the way, he said one thing to me. The kid who called. Good judgment. Too bad he's just a resident now. You're not the same resident you were on day 1. All I do on his team, start with retraction. Same as when you went to Ding Xiaoyong's team. Before you go, wrap up your ED cases. Hand over what needs handing over. Close out what needs closing. Report to cardiac surgery Monday. Yes, sir. Aortic dissection. You should know what that disease is. I do. Then go. In cardiothoracic surgery. Assisted at least once in the OR. Status, not met. Report to cardiac surgery Monday. Yes, sir. Aortic dissection. You should know what that disease is. I do. Then go. In cardiothoracic surgery. Assisted at least once in the OR. Status. Not met. Aortic dissection. Exactly the same as the last one. Surgical mode activated. Perfect grade. Aortic dissection repair ready. Blood pressure is stable. Cardiopulmonary bypass flow is normal. Your turn. Anastomosis complete. Zero leakage. 1. When you called me that night to come here, did you ever think you'd be standing here one day? No. When you finished the anastomosis, I saw zero leakage. A resident shouldn't be able to do that. You taught me well. I never taught you aortic anastomosis. Director Ding didn't either. No one taught you. Next time, you can do it on your own. Director Gu, don't thank me. If you want to thank someone, thank yourself for making that call that night. You made the right call. That's why we're here today. Go tell Xiao Shuchun I'm keeping his resident. Director, Xiao won't let me go. I know. That's why next month, after your rotation, you're back in the ED. But this skill is already yours. Surgical skill LV7. Perfect grade aortic dissection repair. Unlocked. Director, Xiao won't let me go. I know. That's why next month, after your rotation, you're back in the ED. But this skill is already yours. Surgical skill LV7. Perfect grade. Aortic dissection repair unlocked. High-risk checklist rollout. Cardiothoracic surgery implementation status. Director Gu, please. The checklist implementation in cardiothoracic surgery will be reported by the ED drafter. The resident will report at the director's meeting. He drafted the checklist. The high-risk checklist was trialed in cardiothoracic surgery for 1 month. Admission assessment coverage, 100. Pre-op verification compliance, 92. 48-hour post-op monitoring compliance, 88. The two lower ones are post-op monitoring and discharge reassessment, mainly due to fast bed turnover and understaffing. What about neurosurgery's numbers? Neurosurgery is similar to cardiothoracic. Director Chung added a page of detailed rules to the checklist. This approach can be rolled out hospital-wide. The detailed rules work. General surgery has the highest compliance. I posted the checklist by the door. 3 months into the high-risk checklist rollout, the mass poisoning incident in the ED, 0 deaths, and the multi-car accident response, all related to the checklist. In a car accident scenario, what can a checklist really do? What made the difference was the triage protocol. The high-risk checklist includes a priority triage protocol. For mass incidents, 11 casualties. Triage took under 5 minutes. Without that protocol, checking each one would take at least 20 minutes. The difference between 5 minutes and 20 minutes is the difference between life and death. Keep pushing full coverage across all departments. Next phase. Integrate the checklist into the electronic medical record system with automatic alerts. Luhan, you'll coordinate with the IT department. Yes, sir. That dissection you did in cardiothoracic. I watched the recording. Huh. Director Ding watched it too. Guo Wangshan posted it in the surgical directors group chat. 0 leakage at the anastomosis. How'd you do it? Director Gu was standing right there. Him standing there and you being able to suture. 0 leakage are 2 different things. He was just watching you. He didn't do it for you. If you come to neurosurgery, I'll save you a spot. He's coming to general surgery. I trained him on appendectomies and spleens. You trained him on appendectomies? I was watching for the spleens, too. He's ED, he's mine. I'll lent you the scalpel. You're not actually going to keep it, are you? Your ED can't hold on to a scalpel like this. Even if it can't, it has to. He's ED, he's mine. I'll lent you the scalpel. You're not actually going to keep it, are you? Your ED can't hold on to a scalpel like this. Even if it can't, it has to. Jiao Taichung sent you here for a 1-week rotation. I wasn't planning to schedule you for surgery. Director Zhong, but this patient is good for you to observe. The meningioma is located next to the corticospinal tract, right against the motor cortex. I see it. The tumor margins are clear, but it's separated from the motor cortex, nerves by only a layer of dura. Touch it even once, and the patient wakes up unable to move half their body. Can neuronavigation map it out? We'll need intraoperative electrocorticography. For real-time monitoring, it can map the boundaries. It can't map the nerves. The nerves need intraoperative electrocorticography. For real-time monitoring. Have you ever done neurosurgery? No. Working under a microscope is different from open surgery. The field is magnified 10 times. A 1 millimeter tremor in your hand is actually 1 centimeter. Understood. You'll sit at the assistant's position and watch the monitor. You'll hold the retractor, nothing else. Don't touch anything unless I tell you to. Yes, sir. Guo Wangshan told me about that dissection you did in cardiothoracic. 0 leakage at the anastomosis. He said he never taught you, and you'd never done one, but you pulled it off. That's because Director Gu trusted me. He was mentoring me. I'm different. On my operating table, don't move unless I tell you to. Understood? Lu Han. The view under a microscope is different from what you see with the naked eye, magnified 10 times. What you see and the actual distance are 2 different things. Day 1 you watch. Don't touch. Got it. Surgery is scheduled for 9 a.m. tomorrow. Be in the OR at 8:30 to help me set up. Yes, sir. Beginning dissection. The main tumor is out. The remaining edge is against the motor cortex. Motor cortex signals are unchanged. Do we resect this part? Signals are normal. We can resect. Who does it? Beginning dissection. The main tumor is out. The remaining edge is against the motor cortex. Motor cortex signals are unchanged. Do we resect this part? Signals are normal. We can resect. Who does it? You do it. Me? You've been watching for 40 minutes. You should have figured it out by now. You resect this part. I'll be right here watching. Motor cortex signals are normal. Resection complete, 0 nerve damage. Hemostasis and closing the cranium. Motor cortex signals remain stable throughout. No hemiplegia expected post-op. Sent to ICU for 24-hour observation. Director Zhong, how should the primary surgeon record for this case be written? Primary surgeon, me first. Assistant him. I was present and supervised throughout. He performed the primary operative portion. Understood? The part you resected was against the motor cortex. It was a perfect resection. It's because you were there. It made me feel more confident. Me being there and you being able to resect it are 2 different things. I watched. I didn't do it for you. I told you not to move unless I said so. But I did say so. Suturing, drainage, debridement, appendix, spleen, cardiac dissection, meningioma, 8 surgical skills from every department. There's someone you've had your hands on. All of them, yes. Every department had someone watching. A lot of people have been watching you. Not everyone gets to do this. Guo Wangshan watched you suture a heart. I watched you resect a meningioma. You did well on both. If you came to neurosurgery, I'd save you a spot. Director Xiao won't release me. I know the ED has gained a pair of surgical hands. Rotation's over. Back to the ED tomorrow. I know the ED has gained a pair of surgical hands. Rotation's over. Back to the ED tomorrow. Doctor, I have chest pain. How long has it been hurting? It started suddenly, half an hour ago. Like a rock is pressing on my chest. My left shoulder hurts, too. 9:59. The system won't give me the diagnosis anymore. Get a bed in here, hook up the monitor. Check BP, 18 lead, ECG. Draw blood for troponin and D-dimer. Got it. What's wrong? Nothing. Keep going. Any history of heart disease? No hypertension, diabetes. I have high blood pressure. Been on meds for 5 years. No diabetes. Do you smoke a pack a day?
For 20 years.
Any family history of coronary disease? My dad had a heart attack at 60. Extensive anterior wall AMI. Troponin's not back yet. No need to wait. ST elevation. All high-risk factors present. Hypertension. Smoking history. Family history. Send him straight to the cath lab. Notified doctor. Troponin's back. Positive. You'd already confirmed it. Didn't wait for the result. The ECG was enough. Cath lab's ready. Send him in. This AMI. Today. You were slower to decide than before. From patient arrival to diagnosis. You took 3 minutes. You used to take under a minute. Maybe I'm just not in good form today. Not in good form. Nothing. I'll go right up the chart. Not in good form. Nothing. I'll go right up the chart. Fell out of construction site. Chest hit a rebar. Wooddoys. Set 82. BP kilensvenut kotvon. Clearly to key me up. Even the countdown's gone. Move him to the resuscitation room. Monitor and pulse ox. Prep a chest tube kit. Chest tube kit. He might have a pneumothorax. Should we do a chest x-ray first? Wooddoys. Set 82. Can't wait. Percuss first. If there are signs, go straight in. Where does it hurt? Chest. Can't breathe. What did you hit when you fell? Rebar left side. Even the countdown's gone. Left tension pneumothorax. Did you call cardiothoracic? Called. Can't wait. O2 set 82. Wait any longer and his heart stops. Should we wait for Director Ding? Director Ding's in surgery. O2 set, can't wait. Nurse Chun, sterile gloves. You're doing it? I'm doing it. Surgical skill confirmed. Perfect grade. Closed thoracotomy loaded in a muscle memory. It's up to 94. The diagnosis is invisible now, but the hands are still there. Accurate placement. As steady as last time. Tympanic note. Check your shift to the right. The signs don't lie. You're slower than before. I double-checked. Check what? The signs? You never used to. Double-check. Being more cautious now. Drain position is fine. Take an x-ray to confirm. I'll stay and observe. Thank you, Director Ding. Your hands haven't changed. You're slower than before. I double-checked. Check what? The signs? You never used to double-check. Being more cautious now. Drain position is fine. Take an x-ray to confirm. I'll stay and observe. Thank you, Director Ding. Your hands haven't changed. Medical Affairs is looking for you. 2 p.m. It's a complaint. About who? A Mr. Zhou says your attitude was poor. Zhou Jiangua, the chest pain patient from last Wednesday's night shift. Have a seat, Mr. Zhou. Could you repeat what you just said? Last Wednesday night, I had chest pain. Came to the ED. Waited over 2 hours in line. When it was my turn, this doctor said 3 sentences to me and left. Gave me a lab order for an ECG. I asked him what was wrong. He said, we'll talk after the test. Your chief complaint was chest pain. All high-risk factors were present. An ECG was necessary first. I waited 2 hours. You didn't even look at me. 3 sentences, and you were gone. What do you take me for? I call that neglect. The 3 questions I asked were, how long have you had chest pain? Is it radiating to your left arm? Any history of heart disease? He said it hurt for half an hour. Radiating to the left arm. Father had coronary disease. I ordered an ECG, and troponin results showed acute MI. Send him straight to the cath lab. I've reviewed the results. Acute inferior wall MI, PCI performed. Discharged 3 days post-op. That's all true, I survived. But that attitude, I can't forget it. Waited 2 hours, 3 sentences, and I was dismissed. The ECG had to be done immediately. You left before I even finished speaking. Couldn't you have said a few more words? Your medical management was correct, but you still need to watch how you communicate with patients. Yes. I'm not trying to sue him. I remember the life-saving debt. But that night, the way you acted, it stuck in my chest. Third time. I know. This time it's not medical. It's communication. Your judgment is getting sharper, but you talk less and less to patients. I'll say more from now on. What happened? It's been handled. Handled? He felt we were neglectful, but all high-risk factors were present. The ECG had to be done immediately. I know your judgment was right, but while the patient was waiting in line, he didn't know what high-risk factors were. All he knew was you didn't even look up. I'm not tired. If you're tired, take a break. You say you're not tired, but your face tells me otherwise. Isn't that the patient who complained last time? Dr. Liu. Mr. Zhou, how's your recovery? Recovered. Discharged 3 days ago. No heart problems. About last time, I was wrong. After I went home, my daughter looked up what happened that day. She said with my condition, even 1 minute of delay could have been fatal. You still did the ECG for me. You saved my life, Dr. Liu. My dad's stubborn and set in his ways. Ever since he got back, he's been going on about it, saying he's sorry to you. Today, he insisted on coming. There was no stopping him. That day, at the medical affairs office, I said some harsh things. You saved my life, and I filed a complaint against you. I'm sorry, Dr. Liu. I'll accept the banner. What was said that day, I didn't take it to heart. You're a good doctor. If you ever feel unwell, don't tough it out. Come in sooner, okay? This banner looks a lot better than a complaint form. Let's hang it in the observation unit, so all the night shift staff can see it. Sure. What was said that day, I didn't take it to heart. You're a good doctor. If you ever feel unwell, don't tough it out. Come in sooner, okay? This banner looks a lot better than a complaint form. Let's hang it in the observation unit, so all the night shift staff can see it. Sure. Doctor, my stomach hurts. How long has it been hurting? It started this afternoon. First it hurt here in my stomach. Then it moved to the right side. Bring in a gurney. Get him on monitors and check his blood pressure. Run an ECG. ECG first, even for abdominal pain. What kind of pain is it? A dull ache like something's pressing on it? Have you been sweating? I broke out in a cold sweat this afternoon. Add right-sided chest leads. Draw blood and check troponin and CKMB. What are you suspecting? Could be an MI, but his chief complaint is abdominal pain, not chest pain. We need to rule out cholecystitis and pancreatitis. Cholecystitis and pancreatitis can also cause abdominal pain. Right, but his ECG shows ST changes in the right chest leads. Those also elevate the ST segment, inferior wall AMI with right ventricular involvement. His chief complaint is abdominal pain, so it's easy to miss. How can abdominal pain be an MI? An inferior wall MI can present as upper abdominal pain, especially in women and the elderly. Many are missed on their first visit. Troponin isn't back yet. The ST elevation is enough for the diagnosis. Notify doctor. Send him to the cath lab. Right ventricular AMI. Use nitroglycerin with caution. It can easily drop his blood pressure. Got it. Another AMI? Yeah, found through abdominal pain. Right triage. Ran an ECG. ST elevation in V3R and V4R. Good call. Not many would run an ECG for abdominal pain and send them straight up. How long from arrival to diagnosis for this patient? 12 minutes. You used to make that call in 5 minutes. This time the symptoms weren't typical. Chief complaint was abdominal pain. You still caught it, atypical or not. Thanks to the ECG. Who ordered the ECG? I did. Then there you go. Your judgment was sound. You've been quiet lately. Just thinking about what differential diagnosis. You never used to think that long. And now? Yeah, what about now? Now I have to rely on myself. System. Thank you for helping me grow. Just thinking about what differential diagnosis. You never used to think that long. And now? Yeah, what about now? Now I have to rely on myself. System, thank you for helping me grow. Doctor, my chest feels tight. How long? Started yesterday. I thought I'd feel better after sleeping. It's worse today. Any chest pain? No pain, just tightness like someone sitting on my chest. Any coughing? Are your legs swollen? They've been a bit swollen the last couple of days. No coughing. Taken any long car or plane trips recently? I took an 8-hour bus ride back the day before yesterday. Luhan. This patient had chest tightness for 2 days. 8-hour bus ride. Unilateral swelling in the left calf. I went through the checklist. Suspected pulmonary embolism. Good call. Bring in a gurney and get him on monitors. Check his O2 sat and run an ECG. Draw blood and check troponin. I thought I was being paranoid. Anyone would write off chest tightness as a stomach issue. It's on the checklist. Chest tightness plus unilateral leg swelling. Rule out PE. You weren't being paranoid. You did the right thing. O2 sat is 91. Nasal cannula at 5 liters. SpO2. Left calf circumference is 3 centimeters larger than the right. Unilateral swelling. If both legs were swollen, it could be heart failure or kidney issues. Unilateral swelling points to a deep vein issue. You check that too? Item 2 on the checklist. ECG is consistent with PE. 8-hour bus ride, unilateral leg swelling. Hypoxia at 91. Let's do a CT pulmonary angiogram first. Thrombolysis or anticoagulation. BP is stable, so start anticoagulation. Low-dose heparin. If his BP drops, prepare for thrombolysis. Call doctor. You from pulmonology for a consult. Your condition is called a pulmonary embolism. On that long bus ride, sitting still for so long, a blood clot formed in your leg. The clot broke loose and got stuck in your lung. Your O2 sat is 91 now. If it drops any lower, it's dangerous. I thought it was just chest tightness. Didn't think much of it. If a PE goes undetected, a massive blockage can cause sudden death. You came in just in time. Who triaged the PE? Fong Yao saw the patient first. She screened using the high-risk checklist. So the checklist is being used? Luhan wrote it. It's very clear. Chest tightness plus unilateral swelling. Rule out PE. I just followed it. Following it is exactly right. The checklist isn't just for show. I used to think checklists were just going through the motions. This time, it actually made a difference. How long from triage to diagnosis? 20 minutes. Fong Yao locked onto it at the triage desk. Good, keep it up. I was blind before. I thought you were just lucky. Now I get it. What you wrote is genuinely useful. You did great today. I still have a long way to go. Being able to independently triage a PE using the checklist is enough to qualify. Now I get it. What you wrote is genuinely useful. You did great today. I still have a long way to go. Being able to independently triage a PE using the checklist is enough to qualify. Chemical plant explosion, first wave of casualties. 15 arriving in 20 minutes. Mass casualty protocol, highest level 0.8. Activate the highest level mass casualty protocol. Exine, notify general surgery, orthopedics, thoracic surgery, and neurosurgery. All hands on deck. Fong Yao, clear all resuscitation rooms. Chengjia, Prebloth. Notify the blood bank, emergency release. Luhan, you're on front triage. Yes, sir. Is this the auxiliary medical department? Mass casualty incident, all staff report in. Is Director Ding here? He's in surgery. Tell him to come over as soon as he's done. Male, 38, blast injury. Chest pain, shortness of breath. Female, 42, 30 body surface area burns. Male, 50, abdominal shrapnel wound. BP Njolsvon Utven. First one, chest trauma. Fong Yao, take it. Do a chest ultrasound, drain the hemothorax. Second one, burns. Sister Chun, start fluids. Measure urine output. Notify the burn unit. Third one, abdominal shrapnel wound. I've got this. Where does it hurt? My stomach. Shrapnel went in. Fumi and vitals. Exine E2. For lines, prep 4 units of blood. Notify the or to prep a room. First one, hemothorax. Ultrasound shows fluid. A significant amount. Has Director Ding arrived? Still in surgery. Says at least another half hour. Start a closed chest drain. Hand over to thoracic surgery or Director Ding. When they arrive, orthopedics is on the way, 10 minutes out. Thoracic surgery is in the ED. ICU with a resuscitation. They can't break away. Neurosurgery says no head trauma cases so far. They're on standby. This abdominal case might need surgery. When can Director Ding get off the table fastest? Half an hour. Hold the fort until then. Understood. Rumeur en route. Move. This abdominal case might need surgery. When can Director Ding get off the table fastest? Half an hour. Hold the fort until then. Understood. Rumeur en route. Move. Male, 45, blunt trauma to left upper abdomen. BP 020 utven, HR sazhorminsodik. Peritoneal top. Splenic rupture. Notify the or open a green channel. Prep 4 units of blood. What about Director Ding? Xion E. Check again when Director Ding can get off the table. Director Ding is still in surgery. At least 10 more minutes. We can't wait 10 minutes. What's wrong? Grade 3 splenic rupture. Director Ding is still in surgery. Is he or prepped? Yes. Then we go in. Waiting for Director Ding might be too late. Understood. Laceration near the splenic hilum. Still losing. Splenic artery is intact. We can save the spleen. Bleeding stopped. BP is back up, 96 systolic. One more stitch to reinforce, then close. Blood loss under 50 milliliters. Is Director Ding off the table yet? Just got off. He's on his way. What stage are you at? Closing the abdomen. Spleen saved. Splenic artery wasn't severed. Laceration is sutured. Good work. I'll take it from here. Thank you, Director Ding. Dr. Liu, the pneumothorax in resuscitation bay 3. His O2 sat dropped to 80. Tension pneumothorax. Needle decompression. Inserting needle. It's 94 now. Next. Dr. Liu, the pneumothorax in resuscitation bay 3. His O2 sat dropped to 80. Tension pneumothorax. Needle decompression. Inserting needle. It's 94 now. Next, have some water. The burn patient was transferred to the burn unit. The other chest trauma is under observation in thoracic surgery. The abdominal shrapnel case went to general surgery. Postoperativ. The splenic rupture patient is stable. He's in the recovery room. The pneumothorax patient's O2 sat is 96. The drain is holding. How many came in total tonight? 23. All treated, 0 deaths. The surgery chief's group chat is blowing up. What are they saying? Ding Zhang said when he got off the table and arrived. You had already closed. He asked if you did the splenic repair. Chen Baichen also asked whether the neurosurgery patient had a consult. I said no. Intracranial injury was ruled out at triage, directly to observation. He Chamming is asking too. The cardiology chest pain case. Did you request a cardiology consult? Guo Wangshan said in the group. I didn't get a call tonight. I thought he'd forgotten about me. Little Lou, you did very well. The speed of your growth is impressive. Director Zhao doesn't need to say anything. You did it. A year ago, your first night shift. You couldn't even set an infusion pump. Now you handled 23 casualties in one night. Is Luhan here? Yes. I heard about last night. 23 casualties, 0 deaths. Before Ding Xiaoyan even got off the table, you had already done the splenic repair. You didn't delay a single patient. Waiting for the chief. It wasn't just me. Everyone was working the resuscitation. You did the surgery. You did the triage. You made the calls. I checked your record from your first night shift to now. Less than a year. Yes. Headquarters is forming a young physician study group. 1 year of advanced training at Jingshi Hospital. Only 10 people are selected. Jingshi Hospital? That's right. Nice one, kid. Jingshire Hospital. Countless doctors would kill for a spot there. We've been given one recommendation slot. Are you willing to go? It's your call. You decide. I'm in. Then it's settled. Before you leave, wrap up all your current cases. Sure, Gene. You're something else, kid. Don't forget us when you're there. Don't worry. I'll learn as much as I can and bring it back to save more lives.